Welcome back, Rebel EM listeners, to another episode of Rebel Crit. I'm your host, Frank Lodeserto. I'm with my co-host,
Dr. Eric Acker, and I have Dr. Jonathan Bradshaw here with us as a special guest.
Yeah, we have a special guest with us for this Rebel Crit episode, Jonathan Bradshaw. Jonathan, tell us who you are.
I'm Jonathan Bradshaw. I'm an EM resident at PGY3 at Cape Fear Valley Medical Center. Went to Michigan State for undergrad and medical school.
I won't hold that against Jonathan. I'm a Michigan grad. Go blue.
Is that Spartans?
Go green. Go state.
Jonathan, what are some of your interests after residency?
I like critical care medicine. We get a lot of that here in our ER. We get a lot of very critically ill patients that we get to do a lot of critical interventions on, and I really enjoy that aspect of medicine.
Awesome. Well, today we're going to review an article from JAMA published in December 2024 called The RENOVATE Trial by, I'm probably going to mess this name up, Cavaltini et al. And Jonathan's here to talk a little bit about that trial. We're going to go through it. Eric, anything else? Last week we talked about NIV and high flow. They should go back and listen to that episode if they are not familiar with NIV and high flow.
Yeah, that's right. We went over all the NIV, high flow benefits of and how to turn and modify each of those modalities for your patients with respiratory failure. Now we're going to go into a trial that's really going to ask how we manage our patients, how we should treat, and if maybe this trial will change how we should implement these modalities.
Maybe after this, we'll change the way we manage or not. Let's see. So, Jonathan, what was the clinical question that this trial set out to answer?
So the RENOVATE trial looked at the difference between non-invasive ventilation versus high flow in patients with acute respiratory failure. It divided the patients into multiple subgroups, and it was designed to evaluate whether high flow nasal cannula is an acceptable alternative to NIV in the management of these patients.
Acceptable alternatives, almost like non-inferior, but we'll get into that in study design. So what is the primary outcome, Jonathan?
The primary outcome was endotracheal intubation or death within 7 days of initiating treatment.
So we're looking at NIV, non-invasive positive pressure ventilation versus high flow in patients with acute respiratory failure, and looking at intubation rates versus mortality in 7 days. That was our primary outcome. So who was included in this trial?
Patients included were adults greater than 18 years old, hospitalized in acute respiratory failure, and they were divided into 5 subgroups: non-immunocompromised with hypoxemia, immunocompromised with hypoxemia, COPD exacerbations with respiratory acidosis, acute cardiogenic pulmonary edema, and later with the COVID pandemic, patients that were hypoxic due to COVID-19.
Right. So this data was being collected during the pandemic. Is that right?
Yes. From 2019 to 2023 is when they started collecting all the data.
Who was excluded from this trial?
So anyone excluded would be patients with urgent need for intubation, hemodynamic instability, anyone with contraindications to NIV, so that would be like facial trauma, anything preventing mast seal, specific respiratory conditions, which would asthma attacks, acute respiratory failure within 3 days, 72 hours of extubation, post-surgical acute respiratory failure, and then hypercapnic acute respiratory failure due to neuromuscular diseases or chest wall deformities. Other exclusion criteria included patients with DNI or exclusive palliative care, patients, pregnancy, acute coronary symptoms with angiograph within 24 hours, prior long-term NIV, and prior NIV before acute cardiogenic pulmonary edema.
And was there a pH cutoff, Jonathan, any of those?
For the COPD, I believe was 7.15.
Nothing below 7.15.
Correct.
Below 7.15, you're excluded from this trial. So severe acidemia. Okay. All right. So there was a fair bit of patients excluded, but they included a lot of patients in this. Let's jump into the study design. This was probably the most novel approach. A little confusing when I first read it. We were all talking, Eric, Jonathan, and I were talking a little bit about the study design. First of all, it was a prospective randomized control trial, multi-center, which was 33 hospitals throughout Brazil. I'll have Jonathan tell us how many patients, but they used something called the Bayesian adaptive model. So I am not a stats guy, but I had to read this over and over. And so I made a simple analogy. So what a Bayesian adaptive model is basically a trial that changes as it goes. And so I'll give you a quick analogy. Let's say you were studying NIV versus high flow. They have 2 treatments, and it changes based on how the study's going, which is very novel. I'll give you an example of this. Let's say we had 2 boxes, box A, box B. In box A, you have Nike shoes. In box B, you have Adidas shoes. And you want to see which shoes are better. You're going to test it by how fast someone runs in these shoes. So those are your two treatments. Box A, Nike shoes. Box B, Adidas shoes. If they're about the same and you get the same times, that's a non-inferior, which we'll talk about in a second. If one shoe is clearly better, like kids are running super fast times, then that shoe is superior. The trial can terminate earlier because one is superior. Or if one shoe is really bad, like the times are super slow, then that would be futile and the treatment can stop. That's how these Bayesian adaptive models work. So instead of shoes, here box A had NIV, and then box B had high flow nasal cannula. The different treatments were those different subgroups. It also did something unique. It's something called dynamic borrowing. What it does is it statistically borrows from each group to get more precision, only if they're non-inferior. So for instance, if the two groups ran pretty much the same with those shoes, they will average those times and get better statistical precision. But if one shoe's futile or one shoe's superior, they will no longer borrow and they won't use this dynamic borrowing principle anymore. So this is done for statistical precision. It is a little tricky, is a little complicated. I hope that simple analogy helped. But still speaking on studies on how many patients were included in this trial?
A total of 1,800 were included initially, but I believe 34 were excluded for a total of 1,766 that they got all of the data from used in the trial.
Yeah, that's a pretty good sized trial. So we talked about the clinical question, the inclusion, exclusion criteria, the primary outcomes, study design. So let's just get into it. What did they find? What are the results?
So the overall primary outcome, which was the high flow versus NIV, 39% for high flow and 38% experienced intubation or death by day 7, which achieved their non-inferiority goal via their Bayesian adaptive and dynamic borrowing model. What they found per group for the non-immunocompromised with hypoxemia, 32.5% for high flow versus 33.1% resulted in death or intubation. So 33% versus 32.5%. Then with acute cardiac pulmonary edema, 10.3% for the high flow versus 21.3% for the NIV. Hypoxemic COVID, it was 51.3 versus 47%. And then COPD exacerbation, which was interesting to me, is 28.6 versus 26.2. And then with the immunocompromised, the trial was stopped for futility.
So were you surprised by those results? If so, what surprised you?
The COPD exacerbation, typically we think of that as an obstructive pathway. So the use of high flow in that, I thought was interesting that it was non-inferior. Because usually you think you need the BiPAP for the extra assist on the expiration, whereas high flow is typically, it's thought of as just oxygen with maybe a little bit of theoretical PEEP. The physiology doesn't make sense, but the numbers don't lie.
Yeah. We talked about last week in the mnemonic I gave on high flow. High flow can modestly remove CO2 from patients. It probably gives you maybe a modest amount of PEEP. It can cause CO2 washout. It may heat and humidify and help with clearance of secretions. So I was a little surprised, but I've been advocating that you can use high flow in COPD exacerbations for years based on some limited data, but at least I think I have some more data, I think, to now advocate. I don't know about using it primarily, but again, a pretty good alternative, or at least we maybe have two options here. Okay, what else surprised you about these results?
So the acute cardiac pulmonary edema showed 10.3% for high flow versus 21.3%. The caveats to that, they excluded the super sick versions of those. And then they also had a very small number. I think it was 26 patients total comparative to the 1766. Right. Yep. But the 10.3% with acute cardiac pulmonary edema, typically you would think you need the PEEP to keep the alveoli open from the fluid compression and then keep the fluid out of the lung. And so the fact that they had less intubations with high flow than with NIV was shocking to me. And then also, I'm wondering if the reason for increased amount of intubations for the NIV maybe was because those patients need a little help with sedation. So usually they're a little more agitated. They don't tolerate it well. So maybe that was part of it as well, with the high flow being more comfortable versus NIV being less comfortable and needing more sedation with that, which can cause respiratory compromise in and of itself.
Absolutely. And in the secondary outcomes, most of the patients, if not almost all the groups, had to use a lot more Precedex or dexmedetomidine just to seem to tolerate the NIV. But yeah, I was surprised by that. It was almost a trend towards improved outcomes using high flow over NIV. Again, small subgroup, but we did talk about how high flow can generate a modest amount of PEEP based on the flow. I think they started patients with COPD on 30 liters per minute. and in some groups up to 45 liters per minute. So that might be something we could take away to somewhere between 30 to 45 liters per minute. And then they titrated up as the patient felt comfortable. I was surprised to see that. But again, getting into some of the takeaways, I like the fact that I potentially can use that in some of my patients with acute cardiogenic pulmonary edema. Anything else surprising in the results? Maybe talk about the immunocompromised hypoxemic group. That was the only subgroup that showed that NIV was superior.
Yeah, it showed not only that it was superior, but it was almost futile to put them on the high flow nasal cannula.
Yeah, very interesting. I don't know. Maybe there is a little bit more support given in these. It's a small group of patients too. There was not many, 20 in each group, each arm. So anytime we intubate these immunocompromised patients, there are bad outcomes, but we're doing everything we can to prevent it. I don't know if I can truly explain that. That is an interesting finding of the study. Do you have a great explanation for it, Eric or Jonathan? I don't have a great explanation.
A lot of the patients were post-transplant was one of the reasons, and a lot of them chemotherapy. I know a lot of those medications can cause pathologies of the lung. I don't know if maybe they just needed more than the pressure that high flow offered, or if they excluded the acute or extreme illnesses. I don't know if their bodies were at a level where they were close to the extreme illnesses to begin with, so they just needed that more.
Needed a little more pressure, maybe?
Yeah, I think so.
To get them through it, maybe, potentially, yeah. I don't know how much I would make of it because the groups are so small, but it is something thought-provoking. Anything else in the results that surprised you, or just jump into some of the takeaways? Maybe we'll all go around and each give a takeaway point that we got from this study. Eric, do you want to jump in? What is something you took away from this trial?
I think the two things I took away is that high flow, as we talked about during the last episode, I think probably the biggest workhorse there, and my suspicion would be that the aerating and oxygenation of dead space is probably doing a lot of work there, and especially on those COPD patients.
You mean some of that CO2 washout we talked about, removing the dead space and replenishing it with fresh oxygen? And
exactly, yeah. You're using a high amount of oxygen just blowing into this dead space of new oxygenated air. So that has been probably doing a lot of work on the high flow side of things, which maybe that's helping those patients do better in the COPD group. I would just say that the low numbers in the cardiogenic shock group, pulmonary edema, I don't know if I would put a lot of weight onto the high flow in that regard. And I know that in the introduction, they mentioned some improvement in decrease in preload, which maybe that's contributing, but I was surprised by the results because I would have assumed non-invasive would have been superior in general.
Sure.
But
okay. Jonathan, your takeaways?
I was shocked at the acute cardiogenic pulmonary edema group. That was the biggest takeaway for me because I'm in the ER, but we don't typically start high flow in those patients. That is usually a CPAP patient every single day. So that may be something to consider because a lot of people don't like CPAP. They don't tolerate it. And then another takeaway that I thought was true, and it wasn't necessarily one of the study attempts, I think it was a secondary outcome, but comfort was huge. And I think that is a big part in a lot of these patients, especially in the ER. You're thinking, is this sick, not sick? Okay, is this stable for the floor or do they need ICU care? If you get the same or similar benefit with high flow in someone who's more comfortable, you're less likely to give sedatives. And the study did show that. I think that correlates with what I've seen as well. Showing non-inferiority with high flow is very attractive because you can jump to high flow, work with high flow, see where you go from there, and then determine if you need to escalate.
Absolutely. I agree with both of your takeaways. If you have an alternative like high flow, maybe it doesn't change our pattern. Maybe we still put our patients COPD exacerbation on non-invasive positive pressure ventilation, but if they're not tolerating it, instead of going straight to intubation, let's try high flow, or if we see this patient is not going to tolerate it, they're claustrophobic, go straight to high flow. I think we're making too much of non-invasive versus high flow. These are just supportive therapies in general. I think they work similar, and I think we have some now data to show that we may be able to use high flow right off the bat, depending on our patient population, with pretty similar results. So I love this trial. It's been things that I've been saying for quite a while. I've always been a big high flow fan. It just seems like more comfortable. There's so many physiologic benefits from it. And truthfully, personally speaking, if I had to choose between the two and I was in respiratory failure, I would definitely choose high flow just because I am a little claustrophobic and I don't want a mask on my face or to be sedated. I think this gives us some alternative treatments. It's a great study, a lot of great takeaways. Take a look at the trial. Don't be overwhelmed by this Bayesian adaptive model. Keep it simple. There's a lot of great takeaways from this trial.
I was going to ask, of all great trials, how is this going to change your practice? As an ICU attending, are you going to get a patient with a PCO2 of 80 and maybe their GCS is just above whatever the study GCS cutoff was? Are you going to trial high flow on this patient, or are you going to still reach for that NIV?
I wonder if it has a better use. Like ICU, obviously you could use. I think in the ER, it would change my initial approach because we have some patients where you are worried about that preload in BiPAP. And every single time you see someone with a high CO2 and a little somnolent, you're like, crap, blood pressure is 106 over whatever. If I put them on BiPAP, there's a huge, I might have to do push dose pressors for BiPAP just so that they tolerate it so that I can get this flow down. But with this showing non-inferiority with high flow, I do think that offers a lot of benefit, at least in the acute stage of, hey, let's try high flow and see what happens from there. And it should, in theory, buy some time with the non-inferiority and may even be like, no, they're doing great on high flow. I think this is a patient we could comfortably admit to the floor with monitoring or step down unit, as opposed to, okay, let's do BiPAP, shoot, they're crumping. Now we have to intubate.
Sure. So it gives you two alternative pathways.
It does, yeah.
And you don't want to do harm to the patient. So in that particular case, patient is borderline blood pressure. You're worried about the positive pressure effects, dropping the blood pressure, hemodynamic instability. Then maybe that case we try high flow. If we got a pretty agitated patient, maybe we try high flow instead of sedating them and then sedate them, then the pressure drops and put them on pressors. So it looks like we're all favoring high flow here because of the benefits. At least now we have a couple different treatment options. It was all NIV or intubate. Now we have NIV, high flow, and some treatment options for our patients depending on the situation, which I think is great.
And as a test for this study on your immunocompromised patients, this study said it was futile to basically put them on high flow, right? So would you even trial your patients on high flow in that situation? Knowing this study, would you still trial it a little bit, or do you believe the study results enough to implement that?
I think I still would, if it's immunocompromised patient, depending on the circumstance, I probably would try high flow. I'd have this study in the back of my mind. And if it fails, instead of intubating some of these immunocompromised, I would put them right on NIV and then also see how they do there. It's in my mind, but I think I'd still wouldn't change much with those patients.
I don't know if we already talked about it, any limitations here that we're forgetting about with this study of how broadly you can apply.
Sure. So I think that the biggest limitation is the sedation was dependent on how the clinician felt. Each individual clinician was in charge of their type of sedation. There was no standardization of the sedation. And I think that while being a fair way to sedate a patient, calm down an individual, is not necessarily the best thing for a study design because it decreases the external validity in some ways. I think the results are still good. I don't think it takes away from that, but it does take away from the consistency with the information.
Just to clarify, the sedation was primarily implemented in your NIV patients.
Correct. Yeah. Well, a lot of the high flow people did not actually, it was that much more comfortable.
And I think,
they didn't require.
In my personal opinion, that would be a confounder because you're sedating the patient and then they bridge into that GCS low enough that you might feel the need to intubate them. That might give you a signal towards failure of NIV when it might have just been the sedation.
Correct. Yeah, I agree. And obviously some of the medications they use cause depression, so it can worsen their respiratory failure. I think also some limitations were the sample size. I would like to see more patients with acute cardiogenic pulmonary edema and see high flow versus NIV, maybe in that group specifically, because I find it unbelievable, but that's just, I don't know if it's dogma, where BiPAP is what you need more pressure typically.
I think in this particular study, they completely excluded out C.
They did, yeah. So you can put BiPAP on and have different settings. And so we would put the BiPAP on. Yeah. So to see high flow, non-inferior is shocking to me, but that's just based on what we were taught.
There is some preliminary data that high flow has shown some benefit, but small study size.
Yeah.
I think your immunocompromised patient subset was very small.
Yeah.
And also your COPD subset was very small as well. So some people may hesitate and still say, I'm putting them on an NIV, which I think I would still do. I would still treat COPD the same way. But again, if they couldn't tolerate it, I probably would go to high flow, depending on the situation.
I think the other confounder is initially COVID patients were included in first blocks of patients, and then later on they tried separating them out. Some initial data might have been skewed a little bit based off of the COVID populations that were onset of pandemic. People were trying to figure out everything. So that might be a bit of a confounder along the study.
Great discussion. Thank you, Jonathan, for joining us. Eric, as always, thank you. And that's it. Rebel EM listeners, thank you for listening to another episode of Rebel Crit. We will see you next time.